Good morning, good afternoon, and good evening, colleagues. Thank you for joining us for this IASC briefing to discuss the impact of the COVID-19 pandemic, specifically in fragile countries and humanitarian settings. But today's briefing is also an important opportunity to discuss the critical public health and social measures that need to be put in place to better mitigate the impact of the pandemic and ensure our collective ability to sustain life-saving assistance and protection, especially in low capacity and humanitarian settings. For colleagues that do not know me, my name is Mervat Shilbaya, and I'm the chief of the IASC, the Interagency Standing Committee Secretariat, and I'm truly pleased to be moderating today's session. So, colleagues, we've all witnessed the devastating impact of the COVID-19 pandemic across the globe, and a pandemic that, as we all know, knows no borders, and it has ravaged through countries, developed and developing alike, killing approximately 3.4 million people and infecting an estimated 163 million people. Now, it's been a year since the declaration of COVID-19 pandemic as a public health emergency of international concern by the World Health Organization, and yet we continue to witness its devastating impact, and perhaps at an accelerated rate in fragile countries and humanitarian settings. According to the COVID-19 Data Explorer, and Ali, if you don't mind just helping me put the link to this tool that the UN's Office for the Coordination of Humanitarian Affairs pulled together. According to that tool, over a third of countries with humanitarian response plans have recorded more cases in the first 4 months of this year, more cases in the first 4 months of 2021 than in the whole of 2020. More cases in the first 4 months of 2021 in a third of the countries where we have humanitarian response plans than in the whole of 2020. This is just to give you a sense of the impact of the COVID pandemic on many of the countries where we have humanitarian operations. And we're seeing, again, signals and evidence that the impact in terms of numbers of people affected by the COVID-19 has actually increased over the past few months and is projected to increase further in the next months to come. And of the 18.6 million new cases globally reported just in April, over 7.2 million were in countries covered by the global humanitarian overview. That's over 38% of the global reported cases in April, just in April. So in addition to some of these direct health impacts, we're also witnessing the unfolding of some of the secondary impacts of this crisis in many fragile countries and humanitarian settings, including impact on immunization campaigns, on education, on loss of livelihoods, on increased incidence of protection, including gender-based violence. And according to the World Bank forecast, by the end of 2021, an additional 19.4 million people will be pushed into extreme poverty in 17 countries with a humanitarian response plan. So this, colleagues, is just a glimpse of the impact that we continue to see, and that is actually on the rise in terms of impact in many of the countries where we have humanitarian operations that we need to be aware of. So the crisis obviously is far from over and is being felt harshly and strongly in many of the contexts where we are operating. So it's critical to remain obviously on high alert and support efforts to ensure that public health and safety measures to contain the pandemic in humanitarian settings are implemented, while also stepping up innovative solutions to continue to sustain humanitarian operations. Now, to speak to these issues, I'm really very pleased to be joined today by a great panel. Starting with Ms. Fatima Askira. Fatima is the founder and executive director of Borno Women Development Initiative. She has an experienced humanitarian and peace-building professional. She is an experienced humanitarian and peace-building professional and a strong advocate for youth involvement in peace-building and humanitarian work. Fatima is also a member of the African Women Leadership Network and the secretary of the African Women Leadership Network in Nigeria. I'm also very glad that we're joined today by Mr. Altaf Musani, who is the Director of Emergency Health Services with the World Health Organization. Altaf began his public health emergencies career with International Medical Corps in Sudan in 1995. And during the past over 20 years, he assumed a number of critical functions with the World Health Organization, including in Afghanistan in 1999, as well as in Cairo as the regional advisor for emergencies with the WHO Regional Office for the Eastern Mediterranean, and more recently as WHO's deputy representative in Iraq and Yemen. So welcome to Fatima and to Altaf. Last but definitely not least, I'm really also glad that we are joined today by Mr. Samir El-Hawari. Samir is the Deputy Humanitarian Coordinator and head of the United Nations Office for the Coordination of Humanitarian Affairs in Venezuela. Samir has held several positions within OCHA. These include being Deputy Head of Office in Damascus, Syria, Head of Field Coordination in Sana'a, Yemen, and Deputy Head of the Regional Office for the Middle East and North Africa. Prior to joining OCHA, Samir was a research fellow at the Humanitarian Policy Group with ODI. So welcome to all of our panelists. For colleagues that are able to join us today, again, welcome to you as well. And as with usual practice, we will start by hearing first from our panelists, and then we will open the floor for questions and comments. I invite you throughout to please post your questions or your comments in the chat box, and myself and the colleagues online, Ali in particular, will be helping us to make sure that we direct the questions to the relevant panelists. We will record the session, so it will be made available also in case you would like to share it further with colleagues on the ground. So perhaps without further ado, let me start with Altaf. So Altaf, again, is with the World Health Organization. So Altaf, a year into the declaration of the COVID-19 as a public health emergency of international concern, can you give us a picture? And I know I've just shared a few headlines or spotlights on some of this impact, but it would be great for you to give us a more elaborate picture of the impact that this crisis and this pandemic has had or is continuing to have in fragile countries and humanitarian settings. And also, while acknowledging that every context is different, any advice that you can share with colleagues on critical actions that need to be taken to prevent and mitigate the further spread of the virus in low resource and humanitarian settings would be greatly appreciated, Altaf. So perhaps with that, over to you.
Mirvat, thank you very much. And it's a pleasure to be here. And so good day to all the colleagues. I know the presentation is loading up. I'm equally excited to be here with Fatima and Samir because I think what I will try and attempt to do is to give you the wider overview of what's happening globally, but where it really matters is in countries and contexts that both Fatima and Samir and many of the colleagues online represent. So it's really important that we take some of these messages and drive them within the context that we're working under. And having just come out of Yemen, this is something that is very close to our hearts and minds. Next. So I apologize, I've got a load of slides. It's only 10. I promise not to rush through them, but I know that it's a lot of information. And so I'll gently walk us through them. Mirvat, if you find that I'm going over time, please feel free to raise the flag and put the brakes on this. But I wanted to start with some of the overviews. And thank you for clearly labeling out, as of last night, the total death count, the total case count. And of course, we'll come to this in a second, but these are some of the emerging themes that we're starting to see. The world is trying to pivot and turn a corner on COVID-19, obviously with the vaccination at the heart of its strategy, but not the only part of its strategy. And where you picked up is on what we call fragile, vulnerable, and conflict settings. And you started out rightly saying that, globally, the amount of new cases and new deaths are at the highest level since the pandemic. And we know that the numbers continue to change. We know that there are particular areas in particular contexts and countries that show an upward trajectory. Most recently, we've seen what's happened in India, mindful and worrying of what may happen in Nepal, Sri Lanka, Bangladesh, but they're not the only countries or contexts that we are worried about. In particular, the variants of concern. And we won't get too much into this, but again, I'd like to thank my colleagues who helped me piece this presentation together. There are a number of variants of interest as well as variants of concern, which only keep this conversation front and center in countries of fragility, vulnerability, and conflict. Of course, a fourth area that we will try to explore is vaccination. And as you pointed out in the initial introduction, 1.2 billion vaccines have been administered. Sorry, can you just go up? And only 17 million within humanitarian settings. And we'll come back to that through the lens of the humanitarian buffer. And of course, closing down on some of those summaries, the variants of concern, how they're being detected and rolled out and affecting populations of concern, be it migrants, refugees, those internally displaced, those living in hard to reach areas. And then of course, last but not least, is the data issue. We do see global trends, but we know that in a lot of these countries that we represent, the surveillance system is not as robust and as expansive and sensitive enough to pick up, let alone the variants of concern, and address some of the other issues of testing capability and confirmation of new cases. Next. So I did want to share some of the epidemiological profiles. And of course, as the World Health Organization, we do track this hourly and daily, but really just to zero down on a few countries. Of course, if we had more time, I would share with you the entire slide deck, which looks at the number of countries that we cover, and it's anywhere from 31 to 56. But just to look at one particular region, this is known as what we call the Eastern Mediterranean region, also known as MENA. And here again, you see very clearly some of the epidemiological curves with its supporting data. And just to pick out and point out a few. When we look at the situation, particularly in Yemen, Somalia, even more so now in OPT in Afghanistan, those countries, as you pointed out, have inherent vulnerability before COVID-19. And we all know that. That's one of the things that we advocate strongly for as humanitarians. And the question that comes to mind is, how has COVID-19 impacted populations that are already vulnerable? And secondly, something that we're studying is as a result of what is the new vulnerability, and we'll come to that towards the later part of the presentation. But here again, the importance of these countries having data infrastructure surveillance in order for us to start looking at these epicurves, and as another proxy to be able to look at exposure. A number of health practitioners have used what we call unity studies in order to just look at exposure rates in South Sudan as well as Afghanistan. So you see here very clearly, as you pointed out, a rise in cases, and we're hitting the third peaks, the fourth peaks. Next. I wanted to share with you, because this is obviously very important in terms of transmissibility, are a number of the countries in terms of their ability to identify, verify, and manage some of these variants of concern. And we won't go too much into details here, but you see clearly the designation of the different variants of concern. And there are also variants of interest, which we didn't share with you. But in principle, to look at the wide spectrum of countries, everything from Afghanistan, Bangladesh, Iraq, Libya, Nigeria, Pakistan, of which have the capabilities to identify and verify the circulation of those variants of concern. And as we continue to manage and try and contain the COVID-19 pandemic, it becomes particularly important in these countries. Next. A key component, as I started off with, is obviously immunizations. And what's unfortunate is when we look at some of the data, despite the 1.2 billion vaccines administered, only 17 million within humanitarian settings. Now that does change at a very slow rate, but it shows the inequity issue. And just to share with you in terms of statistics here again, of the total percentage of vaccines delivered, less than 20% have gone into what they call low-income economies or low-middle economies. Now, to help us unpack that proportion of populations almost represent 47% of the world's population. So we have a long way to go in terms of getting vaccination under control. Next. Now, to the point in terms of inherent vulnerability, we wanted to also take this opportunity to say that conflict, despite repeated calls from heads of states, our Secretary General, even our Director General, to say use COVID-19 as a way to communicate, conflict has only increased. It did not stop. And here again, when we look at some of the health indicators as well as the humanitarian indicators, they were already dire prior to the COVID-19 pandemic. And then when you overlay the pandemic and you start to see levels of morbidity and mortality in some of these difficult places, we only wonder what will come out of this when we start to look at our humanitarian needs overviews in 2022. We already know that the overall ask has increased. We know that there has been a change in what we call the PIN. And here again, the COVID-19 realities in many of these countries doesn't give us clarity because of those system issues that I referenced. So when we look at testing capacity, not fully optimal in many of the countries, South Sudan, Yemen, northern Syria. And so we need to be able to look at those proxies to really understand what's happening, not only with COVID, but with other issues. So we start to see in terms of access to healthcare, what has happened to aspects such as malaria, such as treatment of chronic illnesses, women and girls who've had issues related to GBV, making sure that they can safely seek healthcare. All those core services that we work for and advocate strongly in humanitarian settings have either paused, disrupted, or become non-existent. And we'll come to that in a subsequent slide. Next. So here again, with this is something that we are tracking very closely as both humanitarian but public health professionals, is the overall incidence of COVID-19. And here the map gives you a graphical representation, is that despite our ability to look at this from a gradient, we know that there are significant gaps. We know that partners have had to scale up in order to address both COVID and non-COVID, as well as health and humanitarian needs. And with those variants of concern, one, and with the low vaccine coverage, we still have a long ways to go, and we need to make sure that we don't slow down our collective efforts on COVID-19 in humanitarian settings. And the big challenge is, what happens if we have a major outbreak in one of these conflict-affected countries? Next. Here again, just to share with you the vaccine equity issue. Those are some of the doses that talk about COVID-19 vaccination. And here again, Mirvit, you and I and some of the colleagues have talked about the establishment of the Humanitarian Buffer as a provider of last resort, knowing well that vaccination is going to be an issue in these humanitarian settings. Equally important, vaccination that is of routine nature, so vaccine preventable diseases, the EPI, the dealing with polio and measles, has also stopped. And we looked at some of the data last year. There was over 166 campaigns in about 60 plus countries affecting 350 million people with yellow fever, meningitis, polio, and measles. And so we now have a collective effort to get that back online as well. Next. I wanted to start to close down and give you a little more food for thought. And despite it being a very bleak picture, some of the services that are vital in order to keep people alive and livelihoods functioning, we know that through pulse surveys, conducted both by WHO and UNICEF, look at service disruption. And they've had several rounds. We're about to embark into the third round. And here again, just a snapshot, you're looking at countries like Ukraine, South Sudan, Yemen, Palestine, Syria, Ethiopia, where you see significant service disruption, which are essential service for people to survive. And how do we now come out of that from a funding issue and an operational issue? And then again, the services that depend heavily on supply chains have equally been affected. So it's despite the bleak picture, there has been a major investment in both COVID-19 and our collective ability to make sure that we safeguard these populations. And just to share with you that when we look at several streams of work, whether it's our ability to test for COVID-19, whether it's our ability to protect healthcare workers or humanitarians using personal protection equipment, whether it's diagnostic equipment or other biomedical equipment, a heavy investment has been made. So those are some of the statistics and metrics which show that change has happened in the country. I'll give you one example. In a country that I just came out of before COVID-19, there was extremely limited PCR capability to detect any pathogen of concern. Now, central public health laboratories have gone from 1 to 9. Other countries are in a similar fashion. We must protect those investments and expand those investments to deal with other other public health concerns. And in addition to that, of course, there's been a heavy investment by the Interagency Standing Committee to look at how do we protect refugees, how do we protect migrants, how do we protect other vulnerable populations, and how do we operate in some of the settings that Fatma and Samir are going to talk about next. So I didn't necessarily want to end on a very negative note. I know that the statistics and everything that I shared with and you addressed are very bleak and very alarming, and we should not slow down our collective efforts to address both COVID-19 and humanitarian needs. But partly the way out is the investment that I talked about in terms of COVID-19, but also for us to also change a bit of the paradigm. We look at humanitarian financing, we look at humanitarian assistance, we look at recovery or development. And again, our Director General has been talking quite consistently that the health security and the health coverage are the same side of the coin. And how do we use that investment case to really look at containing COVID-19, address the capacity for future threats, but also provide service delivery in some of these fragile conflict settings. And possibly the one model that comes to mind is the Nexus agenda. So apologies for being a bit long. I know I'm a bit over time, but just back to you, Margaret. Thank you.
No, Khalis. This is really great, Altaf, and thanks for putting things in perspective in terms of, again, the real impact that we're already feeling in these fragile and vulnerable and humanitarian settings, but also speaking to the positives in terms of some of the progress being made and some of the how we are indeed with continued investments on the ground, whether it's in healthcare systems, whether it's in terms of getting more PPE equipment, diagnostics equipment, PCR testing kits on the ground. The better we'll be able to again mitigate this impact in many of the contexts where we're operating. But again, also the message is quite clear. And again, just a reminder for colleagues that have not seen or are not aware of the global humanitarian overview, just to know that as we look at both the health and non-health effects of COVID-19 as they converge with other shocks that Altaf mentioned, whether it's conflict or rising hunger or the effects of the climate crises, we see the increased number of people in need of assistance, humanitarian assistance and protection. So according to the Global Humanitarian Overview, 235 million people are projected to be in need of humanitarian assistance and protection in 2021. 235 million compared to 167 million a year ago. And already that 167 million already was a record number as it is. So perhaps with that, I want to take it, to move to perhaps to Fatima, who is again the Executive Director of Borno Women Development Initiative in Nigeria. So Fatima, you are based in Nigeria and you've seen and witnessed firsthand the response to the COVID-19 on the ground. So a key aspect of this response is our ability to carefully listen to and effectively communicate with affected people. This was one of the key pillars of the IASC guidance also that was rolled out or published in May of last year. So community engagement and risk communication is a fundamental pillar in the response to the COVID-19. Can you tell us more about measures around community engagement and risk communications that were put in place in Nigeria? How effective are they, and what are some of the lessons to be drawn from this experience? Over to you, please, Fatima.
Yeah, thank you very much, and good afternoon from Nigeria. Of course, a couple and many mediums have been put in place to ensure that effective engagement and communications has been sent to community level and at grassroots level as well. Also, this has been through different organizations and different agencies supporting different activities and advocacies through ensuring that messages are being sent and perspectives are also being changed. One, I would start by saying a lot of visibility material materials that are really a lot of messaging has been developed by many organizations, and you can go in the community, see people wearing the shirts, caps, and hijabs in respect to COVID-19 prevention, as well as getting into conversations around COVID-19 and its effects and its impact. Again, we have utilized various forms through celebrity engagement, where people who are popular influencers have been engaged in ensuring that they are sending the messages on their own platforms, but then through radio engagement, through TV programming, through ensuring that there are jingles here and there are advertisement on different levels where it can reach the most vulnerable, especially radio, that happen to be an easiest platform for many to access information. But then also using music as a tool from local communities, local musicians, local actresses and actors that people resonate with very well. A very typical example in our organization, Borno Men Development Initiative, we use the peer engagements to ensure that we are rolling out messages to the same peer groups at community level, whereby engaging these peer group members through our gender-based violence prevention project, sending message COVID-19, as well as equipping them with information about how they can protect themselves, their environment, but then also sending messages. Similarly, we use also the same platform for advisory group, capturing the attention of traditional leaderships, but also community leadership, to ensure that they're getting the right message, but sending it to the people that they work with. Another good practice is also the utilization of local resource to make protective material for COVID-19, especially where we engage a lot of women to sew the face mask, but then making the local soap to ensure that people have access to soaps to wash their hands, as well as also utilizing the local ash and teaching people in different ways how they can protect themselves, but then keep themselves as healthy as they can. This has also linked closely to supporting mini businesses of especially women and local traders within the community to have access to some of this preventive and protective material. And then local organizations, other international organizations have been able to patronize such individuals that are making this face mask like that. And this is to, access to small business and productions. Again, we have been able to engage with women groups, especially networks at different platforms, to ensure that we are advocating women to women, but then women to children at community level, where we've seen in state like Borno State, where it's very prone. Women-led civil society organization, which is a network, had took the step to ensure that we are reaching out to the most vulnerable communities in terms of market areas, in terms of places where young largely one way that they don't even believe in COVID, and then it's another way to also explain that COVID is real. So it's still a speculation here in Nigeria, not believing COVID and some in COVID. So we're still in a in between, believing is COVID real or not, as it is. But then I would come to also talk about the different stigma associated with this COVID-19, because then even the elite class are still not fully in I can say in acceptance of COVID-19 related issues, and then we're still shying away from the fact that we've seen COVID-19 kill 1 million people in other countries, but we're not taking the most lessons that we're seeing, and we're still kind of joking around with it because we don't take it seriously. But then now back to the vaccine again. Few vaccines are in Nigeria. A few of us are able to access it and book for us getting vaccinated, but it's largely speculated around the vaccine is not a good vaccine, and people don't know what the vaccine is made of. A lot of stigma around it, and this is not only for the most vulnerable population, even at the elite class, because I've seen and engaged many medical personnel from hospitals and from medical facilities saying we're not going to take the vaccines, and because we don't trust the vaccines ABC. So this is stereotype that they're sending to community, and if somebody you trust that is within the medical line is actually sending out a negative signal with regards to the vaccination issue, then how do we expect the vulnerable communities like the IDPs we serve, the refugee communities to now come forward to even accept in taking the vaccines when it is available? Of course, it is not as available as I'm talking about, but the few ones that are here still are facing a lot of stigma. One thing I want to highlight very well is that in a lot of projects, especially in terms of food security related project, we've tried so hard. Unfortunately, this has led to, dragging a lot of time or taking a lot of time when we're doing our activities, when we're doing food distribution, because then you have to also observe the physical distancing. You have to make sure that people are washing their hands. You have to make sure at some point to give the face mask to people to access food, which has a lot of cost implication, but then also it's time consuming. And with the donor funds and the overstretch and the planning, it's really very difficult for many civil society organizations to ensure that this COVID-19 protocols is being sent. And one of the recommendations I would want to make through this is ensuring that during budget cycles, during conversations, these things are really, really prioritized, because the more we are able to ensure that we are capturing them in our programming and sending it to the community, perhaps the more they get to understand how COVID is very real and how they need also to take care of themselves. So this is just a brief from me, and I will stop from here. Thank you.
Brilliant. Many, many thanks, Fatima, and thanks also particularly for highlighting quite a common challenge that we see in many contexts where there are humanitarian operations, and it's largely around that stigma linked to the vaccine. So great to hear you speak to this, and I'm sure there will be questions probably from colleagues online on some of the effective or practical steps that can be taken to address this stigma. And I hear you on the issue of trust, and that's why, again, over and over again, and we'll see it in many of the briefings and the IC briefings that we organize, the arrow always points to the importance of making sure that with our localization commitments, that we do ensure that we work more closely with local actors, because that is, again, a key aspect to ensure that trust is built with communities to make sure that we support them as needed. So you've highlighted also some really, really interesting and good examples of innovative and important ways in which you've been communicating to communities on the ground, whether it's by capitalizing on celebrity engagement or using local music to get the message out with regards to, again, specific steps that need to be taken to make sure that vulnerable communities are protected and do the necessary to avoid contracting the virus. And I hear you also on, again, the interesting and innovative ideas about making sure that locally protective gear, including masks, soaps, are produced locally, which again is necessary to mitigate the impact of the virus, but also creating business or small business opportunities for vulnerable communities on the ground. So thanks a million, Fatima, for some of these examples. And I'd like from here to move to Samir. So Samir El Hawari, again, is the Deputy Humanitarian Coordinator in Venezuela. We'll move to a different context, because Venezuela obviously is a very specific situation. So we'd love to hear from you, Samir, around if you can share your experience on the challenges faced in our ability to sustain humanitarian assistance and protection due to COVID in Venezuela. How were you able to overcome this, or how has the response been able to overcome some of these challenges? And what are some of the innovative solutions that were applied to prevent the spread of the virus and sustain humanitarian operations? And especially any reflections or thoughts on the guidance that was produced by the IASC on preparing and responding in a COVID setting. Any ideas or any feedback on how this guidance has been used? If there are opportunities for us to strengthen the guidance, then that would be really, really appreciated. So maybe with that, Samir, over to you, please.
Okay, thank you very much, Mervat, and thank you also to Altaf and Fatima for really interesting presentations. I wanted to focus on three aspects. I mean, one was the challenges that we faced in terms of scaling up the response pandemic arrived in Venezuela, how we sought to address those challenges, and then what are some of the lessons learned looking forward as we continue to respond. We're at one of the highest peaks globally in terms of the number of cases and deaths. So I think in terms of challenges, I mean, like most HRP countries, when the COVID-19 pandemic hit, I mean, it was a source of immediate concern. It required the humanitarian scale up the response, but also adapting to a new operational context. So this brought around several challenges. And I think it's important to recognize that the government of Venezuela responded quite quickly and established preventative and response measures in March, as soon as the first COVID-19 cases were confirmed. However, we're in a context where the health system is very weak in terms of limited resources, access to personal protective equipment, there's limited water and hygiene services and products inside health communities, also in communities, to prevent. There was also a very limited testing capacity. Initially, there was only one laboratory PCR testing here in the capital. So there was a requirement for important humanitarian support, but also became clear very quickly that the COVID-19 pandemic wasn't just going to have an impact on health. A much wider issue that was going to exacerbate pre-existing humanitarian needs in other. Now, in Venezuela, in 2020, I mean, the economy is estimated to have contracted by 30%. You see high levels of inflation, increasing unemployment, and people essentially reduction in their purchasing power. So this has impacted the vulnerability of people, existed and worsened existing social and economic inequalities, especially for women-headed households who tend to earn less, have less savings, and also more likely to be in various jobs. We also saw vulnerabilities increase for older persons in Venezuela, often struggling with the greater health risks of COVID, but also less able to support themselves in long-term national lockdowns, but also in isolation. We also saw an increase in protection concerns. I mean, the closure of schools meant that a traditional entry point for protection and nutrition programs were no longer there. We saw that the extended quarantine led high incidences of gender-based violence, including increases in reports in domestic violence as well. Due to the COVID impact in the wider region, especially in the neighborhood Brazil and Colombia, we saw over 150,000 Venezuelans decide to return to the country. Now, the government, in order to facilitate the return, required them to stay in quarantine in these dedicated shelters. But the conditions in these shelters were quite precarious. Quarantine was to last for 14 days, but in reality, because the testing results often took longer, then people often stayed for longer periods in these quarantines. And the fact that the borders were officially closed also meant that most migrants or returnees had to use irregular routes, often which are unsafe and exposing them to protection risks, especially for women and children. Also, a number of access constraints that we had to deal with. I mean, the fact that there was a national lockdown meant that there was additional bureaucratic and administrative procedures to follow in order to move. That required special access permits to move across the country, and there was a generalized fuel shortage, continuing operations quite difficult. And also, the closure of airports meant that the movement of staff in and out the country was also impeded, and especially for international NGOs. At the end of last year, there was about 85 staff from 20 NGOs that were waiting to enter the country. So in sum, you had limited national capacities to respond. You had an increase in needs in most sectors. You had the need to adapt to a context of a pandemic. We had some additional access constraints in a context where the humanitarian response was already underfunded. The HRP was funded only 36% 2019, and in 2020 only 22%. So what did we have to do to overcome all of those challenges? Well, I mean, one, I think humanitarian partners were able to adapt, stay, and deliver. And in order to kind of set out a framework for the work that we wanted to do, we quickly developed an intersectoral response plan under the framework of the HRP, where we outlined the emergencies in health and WASH in order to respond to the pandemic. It was really key to also focus on other health needs. I mean, there was already significant needs in the health sector prior to the pandemic. So how did we make sure that those needs were still the focus of our humanitarian efforts? but also provide a platform for other clusters to highlight how the pandemic is also affecting their areas of concern and what was needed to address them. And I think that was important as a tool to engage with donors, to engage with the authorities in order to mobilize additional funding where we could have clear priorities and lay out the scope of the emergency.
Samir, sorry for interrupting you. I can actually hear you very well, but perhaps some colleagues are not hearing you as clearly. So if it's possible, Samir, just to come a little bit closer to the mic, it might help a little bit. Thanks so much.
Is that better now?
It's better even for me. So I hope for the colleagues online, it's okay as well. Yes, better. Great. Thanks, Samir. Back to you.
So with regards to the access challenges, I mean, I think there were also some opportunities. Now, in a context like Venezuela, where the acceptance for humanitarian response is still quite fragile, it's still a very highly politicized context, I think the pandemic helped create a sense of urgency where the additional capacity and support that could be provided by the humanitarian community was actually welcome at the national level, but also at the local level where the engagement with the authorities hadn't been so easy. So I think there was an important opportunity to be had where the capacities of the humanitarian community were in demand. And I think in practice, this resulted in the fact that we were able to support health facilities in terms of medical supplies, provision of PPE, training of the health personnel, also increasing testing capacity and strengthening the surveillance system. And in the end, by the end of 2020, we had supported more than 700 health facilities, and also over 380 had received wash services and supplies. And I think a key adaptation strategy was to put a lot of emphasis on community awareness and engagement, like our colleague Fatima highlighted. So even before WHO guidance was stating that everyone should wear masks, I mean, this was a key message from the government that we also echoed in the communities, because the idea was that by simply people wearing the mask, there could necessarily be a shift in behavior and more consciousness about some of the preventative measures. There was also, in terms of finding, testing, and isolating potential cases, this was very much done in conjunction with the decentralized community health system that exists in country. So the government also put a lot of emphasis in trying to get community doctors, healthcare centers to go mobilize, go door to door, pass important messaging around the pandemic, but also employing alternative testing methods, including rapid testing or clinical diagnosis that could support in a context where there was limited testing capacity. We also provided a multi-sectoral response to the shelters that were hosting the returnees, but very much put a lot of emphasis as well in trying to reduce quarantine time. So advocating for priority testing for returnees, advocating for more decentralized testing. So the testing didn't have to happen in Caracas, but in other locations where there were more returnees coming back to the country, but also eventually supporting in quicker testing capacities with the arrival of antigen testing machines. In terms of some of the other sectors and areas, we also try to make sure that how could partners adapt their response mechanisms to comply with social distancing, but also limit the exposure of vulnerable people to COVID-19. So this included, for example, larger food rations at less frequent intervals to vulnerable households, but also door-to-door delivery in terms of food assistance, which was also the modality implemented for school feeding programs. Likewise, several organizations developed remote assistance, especially for protection services, so psychosocial assistance, legal counseling, case management for families, for cases of family and gender-based violence, which was often done through hotlines or through mobile messaging services. Also for education, how could we strengthen remote learning, so that we often use different technological platforms, including radio podcasts, especially for more remote communities where access to internet was more challenging. So I think in terms of looking forward and lessons learned, I mean, despite the fact that there were important gaps, there's many unmet needs, and at the moment we're at a case where we're seeing, because of the variants, a significant increase in cases in Venezuela, with many health facilities at or over capacities. I think the reality is that given the limited progress in vaccine rollout, I mean, countries that has least vaccine rollout in the region, is that the pandemic and the associated impacts are going to be here for some time to come. So I mean, this is something that's going to be long term. We will see an increase in the humanitarian caseload. So the challenge will be, how can we sustain and scale up the response, especially globally when there's increasing pressure on global humanitarian financing, and Venezuela is one of the least funded HRPs at the global level. So I mean, a key question I think we need to address is, how do we ensure continued financial support in this context? I mean, Altaf mentioned that the nexus and development funding could be an option. Unfortunately for Venezuela, due to the political context, there's very limited development funding. Now, Venezuela is in the quite unusual context where actually, as a middle-income country, they have quite significant resources that are frozen or blocked abroad. So, you know, is there a way how that we can come to some kind of agreements between the political parties, with some of the key actors involved, to use those resources to help fund the COVID response and also the wider humanitarian response? There was a successful example last year through WHO and PAHO, in which some of those resources were channeled through the organization. So how can that necessarily be expanded, also in terms of support for the vaccine rollout? Humanitarian partners, I think, were able to quite aptly adapt their programs in order to respond. And I think the IASC guidance in that regard was critical, because I mean, it's a useful tool that essentially acknowledges that there are many limitations in the low capacity settings in terms of what the ideal guidance would be. So it gives you concrete, I think, ideas on how to adapt, but also how to keep an eye out on some of the most vulnerable groups, and what are ways that we can ensure that their needs are being met. So I think that tool was very useful for us, especially in this low resource setting. I think the importance of community engagement was key, and I think if the pandemic helped accelerate progress in this area. The ACT quickly adopted a collective framework in September 2020, and I think we've better aligned kind of individual approaches by different humanitarian organizations to have a more common approach to ensuring that there's accountability to affected populations, and strengthening the community engagement component of the response. I think we also need to seize the opportunities. I think the pandemic helped facilitate space for more humanitarian engagement. I think we've demonstrated the added value for various humanitarian actors, including NGOs, and I think we're working towards facilitating dialogue and engagement between the authorities and humanitarian actors, so we can ensure better access and acceptance for the response. And lastly, maybe just a word on the vaccine rollout. I mean, I think, you know, Altaf very eloquently highlighted the fact that, you know, the rollout in humanitarian settings is extremely low. That's the case here in Venezuela. So how can we ensure more equity, and how can we ensure that the COVAX mechanism can be more rapidly rolled out, but also expanded? And I think that's going to be key if we're going to see a quicker kind of phasing out of the response to the pandemic, and a greater focus on the existing humanities in country. So I'll stop there, and happy to address any questions.
Great, super helpful, Samir. And I will turn perhaps next once again to Altaf on the vaccine rollout issue, and especially around the humanitarian buffer, and what can we expect on the ground in terms of rolling out the humanitarian buffer on the ground, and what are the expectations, and especially, again, a word perhaps on the importance of the national vaccination plan, and how we need to make sure that in our advocacy with governments on the ground, that vulnerable communities and high-risk marginalized communities can also be part of that plan. So I'll come to Altaf in a moment. And again, I want to encourage colleagues online. Again, I mean, of course, the IC briefing is a good opportunity to, of course, use it as an opportunity to ask questions to our panelists, but it's really also a great opportunity to hear from you, because we know that many of you are on the ground in the front line. So any ideas, guidance, lessons learned that you can share with us here and also with other colleagues online is very much welcome. So please feel free to use the chat box to highlight any good examples or any challenges, particular challenges that you're facing on the ground that we need to also be aware of. It's a great opportunity to share best practices. Samir, thank you for highlighting again how useful the IASC guidance has been. We take advantage, of course, of these briefings to also capture any new lessons to inform, again, the authors of opportunities to strengthen the guidance and make sure that it takes into account the realities on the ground. I think the message is also loud and clear that since the declaration of the IASC's system-wide emergency activation procedures in response to the COVID, the system and the colleagues on the ground have scaled up, have responded, but the challenge is indeed how to sustain the scale up to be able to continue to meet the increased number of people in need of humanitarian assistance, but also address these critical secondary impacts of the pandemic that are having both medium and long-term impact on vulnerable communities. And I'm glad that also we have a number of donors online that are hearing that firsthand. So of course we rely on them to support us with the resource mobilization also efforts in that regard. But thanks also, Samir, for highlighting some of the critical work that is being done on the ground by partners, considering some of these innovative ways to continue to provide humanitarian assistance and protection, including making reference to remote support to provide psychosocial support, remote support to provide protection support, the door-to-door provision of food assistance, amongst many of the other good examples that you shared. So thanks a lot for highlighting these, and again, inviting colleagues to share any other innovative solutions that you've been using and rolling out on the ground. I see a question coming in. Thanks, Gareth, for coming in. And perhaps maybe, Altaf, if I could just turn to you on the vaccination issue while we look at this question and see if other colleagues want to come online with additional questions, and we'll direct it accordingly. So perhaps over to you first, Altaf, and we'll come back to Gareth's question. Over to you.
Sure, thanks. And I think, look, both Samira and Fatma really pointed out that in addition to the public health measures, there's a whole range of activities that are happening in terms of best practice that you mentioned. And I think, we need to capture that, because whatever those best practice work within one context, it's an opportunity for us to learn. We know that some of these measures are being captured in lessons learned for future pandemics. So this is not, this is far from behind us. And I think very specifically on vaccination, two messages. One, there's a huge distinction between vaccine and vaccination, and that's where we are. There is a huge demand and very little supply. And so the Humanitarian Buffer is a COVAX facility. It was established as a provision of last resort. It is very much linked to countries and territories having what you just said, those national development vaccine plans up and running, which should include populations of concern. And as and when some of these scenarios develop where you have hard to reach areas where governments didn't include them in the plan, where it's non-accessible areas or non-government entities, this is where the establishment of the Humanitarian Buffer will play a role. Now, the aim is that it goes live, and this is a COVAX facility, so there are a number of core partners who are equally involved in the management. And this is obviously at the request of Mark Lowcock to be sitting at the interagency standing level amongst the emergency directors. Now, they don't make the decision on who gets what vaccine, but they help to oversight to make sure the equity issue, and they work very closely with what is considered a decision-making group or decision-making body, which are the experts from all the different agencies looking at applications. What's unfortunate is because of supply and demand, we don't anticipate the Humanitarian Buffer having vaccines ready to go. The world is continuing to experience shortfalls, and the original target date was June, and I understand that it's now been delayed till July, if not August. So the application process will go live, but there is a shortfall in vaccine. And then, of course, my last word on vaccine is it's important to remember that it's not just COVID vaccine that children and women need. There are a whole range of vaccination programs that have come to a grinding halt, and we need to get those back online as well. And so the good thing is humanitarians have had a lot of experience vaccinating in these areas. They need to have the delivery costs, they need to have the cold chain, and they need to have these microplans and the healthcare workers to be able to go out and do what they've done best in the past. But of course, now it's down to financing and the vaccine itself. Back to you, Mervyn.
Much appreciated, Altaf. Hear you. I think the message is also loud and clear that for the humanitarian buffer, this is a last resort measure, and hear you that in terms of rolling out of the vaccine, there are of course challenges around the procurement and the administration of these vaccines. And I think in your earlier intervention, Altaf, you were mentioning that only 1% of the total number of vaccines that have been administered in humanitarian response plan countries where there are humanitarian response plans. So we still have a way to go. So, but I hear you also in terms of, again, the importance of relying on national vaccination plans and the importance of the advocacy on the ground to make sure that vulnerable communities, including refugees and other marginalized communities, are part of these national vaccination plans, because the humanitarian buffer, again, it will be a limited supply, and it will be indeed a measure of last resort. So perhaps with that, again, maybe just tackling the question that has come from Gareth, and perhaps if it's okay, Samir, perhaps we can give it, perhaps a shot in terms of, again, an example from Venezuela, around if there are any plans or ideas to integrate other aspects of public health into the COVID-19 response in countries, and to capitalize on any investments or changes in operating environments, such as tackling gender-based violence, contraception, and other routine vaccines. So are there plans to integrate other aspects of public health into the COVID-19 response, including tackling gender-based violence, contraception, and other routine vaccinations? So perhaps, Samir, if you can give just some thoughts or reflections in response to this question from Gareth. And then there is another question that has come in from, one second here, please. There we go. So perhaps following that, okay, so the second question is from Jonathan, I believe. And it is around the equitable and timely delivery of vaccines and therapeutics remains a huge challenge and will likely continue to be so over the short and medium terms. Given these constraints, we will continue to rely heavily on public health and social measures to limit transmission. So perhaps this is a question for you, Altaf, as well. Are there any overall reflections on the experiences so far regarding the acceptability and feasibility of these interventions, masks, hand hygiene, case isolation, shielding, quarantines, and how effective have they been at reducing transmission in these challenging settings? So perhaps with that, this is a question that could probably be addressed by both Fatima with regards to acceptability and the feasibility of interventions such as using masks and hand hygiene and case isolation. So perhaps, Fatima, just speaking to your experience in Nigeria, how well have these measures been accepted? And I again hear that there are challenges on the ground with regards to whether there is indeed belief or whether a lot of the population or people on the ground are actually convinced that the COVID-19 is a real threat or not. So perhaps maybe if you can just elaborate more on the extent to which these preventative measures have been effective on the ground, and then also any reflections, Altaf, from your end, more widely from what you're seeing globally in terms of any challenges that you're seeing that you can also share to respond to Jonathan's question. So, so can we start perhaps, Samir, first with you on, again, that response to the question from Gareth on integrating aspects of public health into the COVID-19 response, and then we'll turn to Fatima on the feasibility of the interventions, the preventative measures or interventions, including the use of masks and hand hygiene and so on, and also reflection from Altaf to that same question, please. Over to you first, Samir.
Thank you, Mervat, and thank you for the questions. I mean, I think with regards to the public health measures, I mean, I think a lot of these challenges in public health were pre-existing. So, there was very much a focus on sexual and reproductive health. There was very much a focus on vaccine rollout for the vaccines. So I think what happens is that when the pandemic started, all of the focus and the limited resources that existed were very much channeled towards responding to the pandemic. And I think that the needs in the other areas essentially been exacerbated with the pandemic. So whilst the less resources have gone into those areas, the needs have increased. And I think that there's been a collective recognition that they need to ensure that how can we maintain those services and where possible also increase them. So I think what the pandemic has helped do is to say, okay, what innovative mechanisms can we make sure that those resources are maintained? How can we also ensure that more resources can be channeled to those areas? So, and I think now we've come to the stage where 1 year on, that we essentially are not just focused on the COVID response, but also on the associated impacts within the health sector. So I think that that's very much been accepted now to see it in kind of a more comprehensive way. And I think it took some time to get there, but I think now very much recognition within the resources available. How can we essentially the response in those areas in the context of pandemic and still having a national then with regards to the vaccine rollout, I mean, I think the additional challenge, which I think was highlighted very well, was one thing is also getting the vaccines in country, but then is the whole infrastructure to administer the vaccines. And I think we in a context where there's issues with the cold chain. There's issues in some of the remote areas. I think the fact that that will be strengthened through the COVID response, I think is also a great opportunity for wider vaccines in areas. And that's an opportunity, I think, that shouldn't... And I think in terms of the community engagement, the community approaches, I mean, I think in Venezuela we're quite lucky that those community systems and networks existed. So really they were an important mechanism to channel messages. And I think that we will continue to use those mechanisms for the general response, where there needs to be important messaging around protection, around where they can get access to services, and trying to understand what people's needs are, what they want, etc. So I think we can very much take advantage of those networks that they've very much been strengthened in the context of the pandemic. Then maybe just lastly, to also highlight that on the issue of the local actors, I mean, we very much agree on the need to make sure that resources are arriving to the local actors. We recently established last year a humanitarian pooled fund, a country-based pooled fund for Venezuela, where we're very much hoping that the resources that are being channeled through the fund are reaching local actors. First allocation that was done just last month, which focuses on sexual and reproductive health. We're basically funding 12 NGOs, 11 of which are local actors. So I think those are some of the platforms that we're using to make sure that more local actors can receive funding directly.
Great, thank you, Samir, and thanks for answering Danielle's comment on the need and the importance, of course, of funding local actors who are, of course, at the front line and, of course, who are critical in carrying out, again, being at the front line, but also the critical role that they play in communicating with communities. So maybe with that, I'll turn to Fatima, perhaps, on the question from Jonathan on, again, the feasibility and the acceptability of these interventions, the use of masks, hand hygiene, case isolation, and so on. Over to you first, Fatima, and then we'll turn to Altaf.
Thank you very much again. And when I saw the question, it was really something on my mind, because, speaking about people with stereotypes and even not accepting the fact that the COVID-19 is real, or it does as much damage as we are looking at. But then in terms of utilizing the PPE material, especially the face mask and all the other restrictions and things, we've seen a lot of people really being more careful about excessive travelings and moving around and stuff like that. Even at the elite level, conversations around it's better to stay home than go out there, because people are unsure of what the impact of this COVID-19 could be. Even though currently in Nigeria, we haven't seen, much of a wave, especially at state level, at community level, at grassroots level. We haven't seen outrageous number of cases that has happened, but then we've also seen a little bit of people accepting the existence of COVID-19 at the initial stage, and then later on it kind of dropped down on how people really believe that the utilization of this face mask and other protective material is important. However, we still have within the community, especially within humanitarian organizations and development partners, still taking it very, very seriously, avoiding social gatherings. But at normal community level, it still do happen. And then the unavailability or lack of abundant places for testing facilities, especially where I live, for instance, is also one of the things that we could say is a barrier, because it's very difficult for one to just go up front and then get tested for COVID and be sure that you're COVID free. So practically or basically, you can't tell who or not is COVID-19 positive or not. So it's really quite tricky here in the context where we operate, and that is why it is very, very important we continue to strengthen and ensure that we are engaging more with the community, and then we are not relenting, because over time we've seen how at the initial of COVID-19 everything was going perfect. People are becoming advocates for COVID-19. We speak out about it, but not anymore as it used to be. And then we are seeing a second wave from other countries like India, where we are now recording a lot of mortality rates and stuff like that. But then we are not even taking into considerations that this is a second wave of COVID-19 and can affect any country, especially here in Nigeria and where I live. So it's very difficult now to say how like when accepting between utilization of the protective material and then even believing that COVID-19 itself is existing. So it's quite tricky, and a lot need to be done in terms of engaging with communities, but sending communications out. Lastly, I would like to brush a little bit about gender-based violence, especially when somebody mentioned the SGBV. We've seen a rise in SGBV crisis, and this has primarily been linked to economic impact of the COVID-19 on many businesses, especially here. For instance, in Maiduguri, we spent amidst all of this hardship, we spent 3 months or 4 months now without electricity. And you can imagine how entrepreneurs are actually managing to strive on small businesses. But then also with COVID-19 restrictions around travels, around many other activities, it's also, making people to panic around. And this has a great deal really impacted more on raising the issues of sexual and gender-based violence, because on many streets you go, you find children begging, you find women begging, you find, a lot of distressed people. And this, you can't unlink it to the economic hardship that these processes and this whole phase have shifted on people. So it's really a matter of more and more engagement and sensitization, but then also the government stepping into its responsibility, as well as more humanitarian donors and development partners supporting these people, but then also in terms of livelihoods, activities, and overall food security. So I would stop from here. Thank you.
Thank you, Fatima, and thanks again for confirming that also in Nigeria we are seeing that one of the terrible impacts of the COVID is indeed the increase in incidence in sexual and gender-based violence. It's something that we're seeing also in many other contexts, and speaks again beyond the direct health impacts. There are other critical concerns that we have to be alert and well positioned in working with local communities and working with governments to make sure that we address as a matter of priority. But perhaps just turning to Altaf as well for any thoughts or reflections to respond to Jonathan's question on, again, how feasible, again, has it been in context beyond Nigeria, maybe just as a global, global reflection perhaps on what you are seeing or what you are hearing in terms of our ability to indeed roll out some of the good examples or guidance that we have seen in the guidance that was rolled out in May 2020 around responding in low capacity and humanitarian settings. Are you seeing traction in terms of the ability to apply, again, these preventative measures around isolation, detection, use again, social distancing, using of course, washing hands, using hand sanitizers. Has there been traction in many of the humanitarian settings, or are there challenges that colleagues online should be aware of, and what can be done about it? Over to you, please, Altaf.
Mirva, thank you. And you're absolutely right. It's that IASC guidance that was put out earlier, which talks about the public health and social measures. So again, as another point of reference, does that work in various countries and contexts that we work in? I think another important point, and Ali has put the link out, that our organization has a multiple of partners, be it Johns Hopkins, ACAPS, the Centers for Disease Control, the London School, that are also looking at the application of social measures. And the short answer is it's a very diverse mixed view. You can see this already in the world that we live in. And I think there are three major areas when we unpack that issue. One is the messaging. And here again, our institutions across the board have called for leadership, because the pandemic has been the accelerant for what we call an infodemic, where there is fake news, false messaging, incorrect evidence, which really confuses the average individual. So the rise of the infodemic is something that I know a number of us as agencies are tackling, and making sure that we get the right information to the right people. So that's number one. Number two is the availability. And in the context that Fatima just described, as well as what Samir faces every day, the availability. When we talk about hand sanitizers, I mean, this is very much of a modern concept. We represent areas where soap and water is the substitute, but it's not even available. And so just to say hand sanitizers, or even wash your hands, we know that the incidence of diarrheal disease will plummet if you use soap and water and hygiene measures. And so we were struggling with that pre-pandemic, and I think it certainly becomes even worse as a result of pandemic because of availability. And then, of course, the third key issue is acceptability. Fatima talked about this. There's a lot of fear, stigma, lack of confidence within the health system, lack of confidence amongst the leadership in terms of what is this pandemic, and even more so, I won't name the country, but we were just on an IASC call, and vaccine hesitancy is equally prominent amongst humanitarian workers. These are our colleagues online who have concerns about the vaccine and say, I will wait and see, or I will pick and choose. And so, again, a very mixed view in terms of the uptake. I know that a number of my colleagues, both within the global clusters, but particularly within the health cluster, have task teams that are looking at particular country contexts, best practice, and using the advocacy platform that we've established through the humanitarian country teams to really stamp out some of the bad practice, or address the reality of acceptability and availability of PPE and soap and water. So I think we've got a lot to go in terms of ahead of us. The good thing is the pandemic has given us another window. And I go back to the point I made earlier, the investments that we have made because of global solidarity, because fighting a common pathogen, we have to garner those, we have to flourish some of those investment cases. And whether it's RCCE, whether it's better community engagement in terms of understanding behavior, or some of the root causes of the humanitarian assistance that is needed, this is our time now. And I'm a bit worried that the window is shrinking. Back to you.
Great. Altaf, I will count this as your closing remarks as we wrap up this session. And I really want to also give the opportunity for both Fatima and Samir to share any final reflections or thoughts as we conclude this meeting. But just a word of a huge thanks to the three of you, really. Thank you, Samir, thank you, Fatima, and thank you, Altaf, for making the time. And thanks also to the colleagues that made time during their very busy schedules, being at the front line to dial into this call. I hope it was useful. I think the messages are really clear that the crisis is far from over. We are starting to feel it aggressively in many of the fragile countries and the humanitarian context where we're operating. The point that you've made, Altaf, around investments, we're reaping the results of investments that are made, especially if they're made early. It doesn't mean that it's over. A lot more needs to be done. To the point that Samir made, which is, again, we've stepped up, we've worked with local communities, we can do a lot more to work even more with local communities, civil society organizations, and governments to make sure that we scale up even further, but resources are required. To the point of availability, again, Altaf, that you've mentioned. Again, the good examples, Fatima, that you've mentioned around innovative solutions to engage with and communicate with communities on the ground. The issue of trust and addressing stigma is critical. And the only way to address the trust deficit is by working through local communities and community leaders, including, again, the women-led organizations, Fatima, that you've mentioned. A long way to go. And this is not obviously just about responding to the direct impact of COVID in terms of the number of people being infected and the number, unfortunately, that are passing away because of this terrible pandemic, but these secondary impacts that are being felt now will be felt for the long term if we don't keep, again, that pressure on and maintain that alertness to ensure that we address and sustain, again, humanitarian operations and protection on the ground. So maybe just any final words, advice, Fatima, from your end before I move to Samir for his final thoughts. Over to you, please, Fatima.
Sure, thank you. I think for me, finally, I would like to call on all the humanitarian development agencies that are working, especially in the conflict-affected countries, to ensure that we are not tired of reaching out to communities through our different interventions, ensuring that we are carving out the right messaging to reach out to grassroots communities, to accept the fact that COVID-19 is real and then the vaccine is free and safe, and ensure that we are encouraging people by being good ambassadors ourselves. Because at some point, if people trust us with our work and we're not taking the leadership and showing to them that this is a genuine, then they are not really taking it, because I can't advocate for what I am not being part of. Then lastly, again, we have to continue to link all our interventions to livelihood, especially with regards to economic activity, so that people are actually benefiting from our work, but then we are leaving them at least with a point of sustainability, because definitely humanitarian is not going to be staying there forever, but then the communities need to be as resilient as they can be. And the only support we can give to these communities is ensuring that we are adding a value chain in terms of supporting their economic activities, small businesses, but then also encouraging, local patronage of local commodities, as well as buying from within, and making sure that we are always given with regards to preventive materials of COVID-19 for communities to be safe and free of COVID. Thank you again for the opportunity. I really appreciate to be on this platform today. Thank you.
Thank you, Fatima. And I can see also a couple of comments from Breda in the chat box, speaking to the importance of, again, of supporting frontline health workers, midwives, traditional healers, local political and religious leaders. These are really critical to address, again, the trust issue that you spoke to earlier as well, Fatima. Thank you, Breda, for highlighting these important points. So with that, over to you, please, Samir.
Okay, no, thank you. I think I would like just to keep highlighting the fact that there's, obviously a need to keep scaling up the response. The pandemic is far from over, and I think we're at a stage with the new variants that we will see increases in cases. Now, in order for that to happen, that requires an increase in financing from the traditional donors. But as I mentioned, I think we also need to look at innovative ways. And case of Venezuela, it's a country where the national resources do exist. So how can we mobilize those national resources to provide financing for the response? I think access is another issue that we need to improving, and how can we build on the gains made so far in improving access for humanitarian actors in different parts of the country. But also to put a lot of emphasis on the vaccines, on how can we have a more equitable distribution of the vaccines? How can we make sure that once the vaccines arrive, the infrastructure can be supported so they can be administered, the communicational aspect also be strengthened so people take up the vaccine. And I think that's key. If in the medium term we want to see that the subsides, and we can have a greater focus on other associated needs, but also the other border needs in there.
Great, super helpful, Samir. Thanks for highlighting the point also around access in particular, and thanks for mentioning that with the COVID pandemic, this has also opened up new opportunities for strengthened and improved engagement also with the government. So thanks for highlighting again these good examples. Altaf, I don't want to strip you from the opportunity to say any final words before the messaging, availability, and acceptability message that you already relayed, but any final points before we conclude?
No, again, it's been a pleasure, and I think we need to continue having these conversations. For what you pointed out, we still have a long road ahead of us, and whether it's vaccine hesitancy, whether it's pure humanitarian needs, I think this group and the larger humanitarian country teams that we work to support, need to help us, create those clear messages, because I sense there's going to be a shortfall in funding, but certainly not a shortfall in needs, and I think the more we can create granularity in terms of what those needs are and how we use COVID-19 as the investment case to change behavior, increase health-seeking behavior, or changing the paradigm in some of these complex countries. I mean, I think everybody agrees if we can get warring factions just to stop fighting and create some peace and tranquility around COVID-19, we certainly would see a big dent in COVID-19, as well as some of the other humanitarian needs that we're going to continue struggling with. So thank you for the opportunity, and we look forward to sharing information with you to help you, do your job better. And a real shout out for all the countries and frontline workers who are doing that difficult task. Thank you.
Absolutely. Thank you, Altaf, and really huge thanks to you, to Fatima and Samir again, and huge thanks again for colleagues that were able to join us today. And thank you for everything that you're doing in the front lines. I know these are extremely challenging times. Please stay safe, and a belated Eid Mubarak for those who were celebrating. All the very best, and thank you so much for joining today. Thank you.